Hello everyone. So today we have yet again come across, going to take one more obstetric topic, a beautiful, a really interesting topic, and also exam point of view, one question for sure from this topic. So the topic is normal labor and normal puerperium. So we'll be studying what is normal labor and what is normal puerperium, and also I've added a few conditions which related to any abnormal conditions they have added here itself so that simultaneously we can study that. So coming to the first topic, normal labor. So what is the normal labor? We all know what labor is, but what are the criteria for it to be called as normal? So we'll be seeing that. So the definition of normal labor is, it is a series of events. It is not one event or two events. It is a multiple number of events which is occurring together that takes place in the genital organs in an effort to expel the viable products of conception. So viable products are living products of conception, and these products are fetus, placenta, and the membranes. So these three, the effort taken by the mother to expel the viable products, and it takes place which area? It is in genital organs, and out of the womb through the vagina into the outer world is called labor. Now this is just labor. Now, what is preterm labor? So there are two terms which you shouldn't get confused. Is one is preterm labor and pre-labor. So whenever a question comes up, I request all the aspirants to have proper clarity with preterm labor and pre-labor. Okay, so preterm labor is any labor, any effort or series of events, this definition occurring before the 37 completed weeks. This is preterm labor. So pre-labor, what it is, we will see further. Now, normal labor also is called as eutosia. Eutosia. So I always emphasize on remembering the other name of any condition, any terminology. So the other name you should be remembering. So normal labor is also called as eutosia, and labor is called normal. So we saw this is just a definition of labor. Whatever we saw this is just definition of labor, but this definition to be called or to be applied as normal, what are the criteria? So for it to be called normal, it should fulfill the following criteria. And what are they? So the first one is, it should be spontaneous. The onset should be spontaneous, not gradual, and it should be at term. So the mother should have completed the term weeks or term pregnancy, and the presentation of the fetus should be vertex presentation. This is normal. And if a fetus with vertex presentation goes into a labor, then it is called normal labor. And then it should not have any prolongation, without undue prolongation, because there are few conditions associated with prolongation. Those are all not there. Conditions are very secure environment or very proper for the delivery of the expulsion of the fetus. Then it will not be undue, there will be no undue prolongation. It will be on time. Next is, it is natural. You don't have to give artificial expulsion of fetus. So it is natural termination without a minimal aids. So natural normal. So full term normal delivery is called why? Because the assistance is minimum there. So LSCS is different from normal delivery because the assistance is minimum, and there shouldn't be any complications affecting the health of the mother or the baby. So both are in the picture, not only the mother or not only the fetus, it is both. So these are the criteria for a labor to be called as normal. So this can be asked as the except none of the above or all of the above or except one. So you should be remembering the points. So first one is spontaneous in onset and at term, should be vertex presentation. Any other presentation is associated with few complications. That is why it is not normal, and without undue prolongation, and it should be natural termination with a minimal aid and without having any complication to both mother and the baby. Next, what is abnormal labor then? When we see normal, we have to know abnormal also. So remember the term for abnormal labor, it is dystocia. Dystocia. This means we know it is difficult. So difficult labor is dystocia, and that is called as abnormal labor. And any deviation, so we saw criteria in the previous slide. So any deviation from those criteria, even one of the deviation is there, then it is abnormal labor. So any deviation from the definition of normal labor is called as abnormal labor. Next is date of onset of labor. So how do we know priorly, okay, this could be the date of onset of labor for a mother. So that could be, or a pregnant lady. How do we know? It is through Naegele's formula. Even in diagnosis of pregnancy, when EDD had to be calculated, we came across this. So just Naegele's formula can only give a rough guide as to what is the date of onset of labor, because EDD means expected date of delivery. So with that relationship, we can understand, or we can get to know what could be the, and this is not 100%, it is not at all 100%. It is just a probability that this could be the date of onset of labor. And based on the formula, labor starts. Now, what is the formula? The formula is you have to know the LMP, or the last menstrual period. That means first day of last menstrual period. And to that date, that LMP, you should add 9 calendar months. 9 calendar months plus 7 days. Plus 7 days. This will give approximately, approximately EDD. And this is called as Naegele's formula. Naegele's formula. It will come up in one more slide. We will, with an example, let's solve it. Okay, so based on the formula, Naegele's formula, labor starts approximately on the expected date in 4%. Only 4% on expected date. That means you have calculated the EDD. Only in 4% of pregnant women, we can expect the same day labor starts. And 1 week on either side by 50%. 1 week. So, for example, today is the EDD for July 28th is EDD. So 1 week minus 1 week or plus 1 week of this date. In 50%, we can expect. So 1 week on either side of in 50%, and 2 weeks earlier. 2 weeks earlier. So minus 2 weeks in 80%. So most probably the EDD calculated, and if suppose EDD is calculated, there is a date that is calculated 2 weeks prior to that date. We have to expect in 80% of cases the onset of labor, and this is much applied to a primi gravida, and 1 week later in 80%. So minus 2 weeks or plus 1 week in 80% of pregnant women, and at 42 weeks in 10%. In 10%. So this is usually after the term period. So this is in 10%. So the most highest is this, and you should remember this. So which is the closest EDD or on date of onset of labor according to Naegele's formula? It is 2 weeks earlier and 1 week later in 80%. And 43 weeks plus is in 4% of pregnant women. Now, what is Naegele's formula? As we saw, it is to calculate the EDD, means expected date of delivery, and it should be added. Adding 9 calendar months and 7 days to LNP is the Naegele's formula. For example, easy example is 1st January is the 1st Jan is the LNP, and we have to add, because Naegele's formula can come as the formula in question also to calculate the EDD. It could be a probable question. So 1st Jan. So to this 9 calendar months. So the month of Jan is 1, right? Plus 9 is 10. So it is October. And to this we have to add 1st Jan, right? So we have to add 7 days, the day of LNP. So it is 8. So it is 8th. So the EDD is 8, 10, whatever year it is. Okay, so here this is the EDD calculator, and the most probable date of onset of labor can be minus 2 weeks of this date and plus 1 week of this date. So this is the Naegele's formula. So for onset of labor, which is the formula that is most probably used to calculate, is Naegele's formula. Next, what is pre-labor? So I was telling that you shouldn't get confused between preterm labor and pre-labor. So pre-labor is a stage of which goes into the true labor. So pre-labor, it is a pre-monitory stage of labor and begins 2 to 3 weeks before the onset of true labor in praevi gravida and few days before in multipara. And it is associated with increase in oxytocin receptors in the myometrium. So because oxytocin comes into the picture in the labor, so it is associated with increase in oxytocin receptors in myometrium. And the changes seen during pre-labor are, so what are the changes which can suggest that the pregnant woman is going into a true labor? So the premonitory stage or premonitory signs are, first one is lightening, that is decrease in the fundal height seen at term, and this is due to the formation of lower uterine segment of the uterus, which allows the presenting part to descend into the pelvis, and it brings a sense of relief to the mother. So first one is lightening, and then cervical ripening, so that is softening of the cervix. So we have to understand all these signs or all these changes are happening. Why? For the smooth delivery or expulsion of the fetus and placenta. And false labor pains. So if it is a true, so always remember, true labor pain is only seen in true labor. It is not seen in pre-labor. So pre-labor is always characterized by false labor pains. Next, what is a true labor pain? So true labor pain, these are the criteria for it to be called as true labor pain. First one is it is painful. Painful uterine contraction at regular intervals. It is not that it comes once, goes and again comes. So it is not irregular. It is regular interval and the frequency of contraction keeps on increasing. So the frequency, intensity, duration. So these three things, frequency, intensity, and duration, it keeps on increasing. So the intensity and duration of contraction increase progressively and associated with show. So there is something called show. We will see further what is show. And progressive effacement and dilatation of cervix, descent of the presenting part of the fetus, and formation of bag of four waters, not relieved by enema or sedative. So these are the criteria for it to be called as true labor pain. So now, if these are the criteria, then what is false labor pain? So false labor pain is dull in nature. It is not a severe pain. It is a dull aching pain, and it is confined to lower abdomen and groin, and it is not associated with hardening of the uterus, whereas in true labor pain there is hardening of the uterus, and they have no other features of true labor pain like show, like effacement, cervical dilatation. So these features will not be seen in a false labor pain, and usually the pain is relieved by enema or sedative. So this is false labor pain. So this is a table which if you can remember well and good, because it can be asked in match the following kind of questions. So the cervical changes, dilatation and effacement is present in true labor pain and is not present or absent in false labor pain. Frequency and duration of contraction keeps on increasing, gradually increase, and it is regular in nature in true labor pain, whereas in false it is irregular. And pain where it is felt, in true labor pain it is lower abdomen, it is back, it is radiating to thighs. But in false labor pain, it is only in the lower abdomen. Next, bag of water. It is formed in true labor pain. It is not there or absent in false labor pains. And show is present in true labor pains and absent in false labor pains. So what is a true labor now? We saw what is pre-labor, then true labor pain and false labor pain. Now what is true labor? So onset of true labor is characterized by appearance of true labor pain. So once true labor pain starts, it can be confirmed that the pregnant woman is, or the woman is going to the stage of true labor pain, true labor, and appearance of show. So this is one of the important sign for any obstetrician to confirm the onset of true labor. So appearance, these are the two main criteria for it to be called or for it to be understood that the true labor has started, the onset has started. Now, true labor is divided into 4 functional stages. So remember functional stage. So they are first stage, second stage, third stage, and fourth stage. So these are the four stages, four functional stages. So each stage we will see what are the changes. So main points have been covered, which is in interest with the examination point of view, the competitive examination point of view. So stages of true labor. First stage, what happens? So again, in obstetrics, you have to remember the weeks, very important, and the measurements, and also the time period. So all that is very important. So I just tell all aspirants to make a note of everything, weeks, time period, and any measurement that is come across. So first stage, it starts with the onset of true labor pain and full dilatation of cervix. So this should be remembered, as the question can be twisted by getting, so they will try to make you confused between first, second, third labor stage with the definition. So just remember when the true labor pain has been started and when the full dilatation of cervix has been completed, that is to till 10 centimeters, which is ideal for the fetus to get expelled or for the fetus to be delivered. So with this, the first stage stops. That means first stage is completed. So the duration is about 12 hours, 12 hours in primary and 6 hours in multi-para. So second stage is, it starts with full dilatation of cervix and ends with expulsion of fetus. So when the fetus is delivered, second stage is completed. So expulsion of fetus from the birth canal, and the duration is 2 hours. So the longest stage of true labor is the first stage. So this can be a question, which is the longest stage of true labor? It is the first stage. And then second stage is 0 minutes to 2 hours in primary and 30 minutes, max 30 minutes in multi-para. Now, third stage, it begins with expulsion, after expulsion of fetus, and ends with expulsion of placenta and membrane. So always don't get confused. In second stage, the fetus is out. The fetus is delivered. The third stage is exclusively for the placenta and the membranes, which is also called as afterbirth. Afterbirth. Okay, afterbirth. That means after the birth of the fetus, whatever is remaining in the uterine cavity, it is mainly it is placenta and membranes. So third stage is, it is expulsion of placenta and membranes. The duration is 15 minutes usually in both primary gravida and multipara. The duration is, however, reduced to 5 minutes in active management. If active management is done, then it can be reduced to 5 minutes. Next, there is the fourth stage, and this is the observatory stage. So it is 1 hour observation period after the delivery of the placenta, and physiological chills are experienced by the mother in this stage. So this stage is very important when it comes to complications of after delivery or complications after the labor. So the lady is monitored, the mother is monitored for 1 hour. So to see whether there are any complications and to take care of those complications. Next, what are the causes for onset of labor? What is the reason for the onset of labor? So these are the main reasons. One is uterine distension. After the term period, the uterus starts distending so that the force to be given to expel the fetus. Next, fetoplacental contribution. Estrogen, so hormones coming into the picture, progesterone and prostaglandin. So these are the 5 main contributors or 5 main probable causes of onset of labor. So here you can see what happens. So it is a series of events. We saw what is the definition of labor. So it is a series of events. So the first, let's start with placenta. So placenta, what happens? So it starts releasing cortisol releasing hormone. So if you see in the question related to labor, there is cortisol, don't think it is not related to labor. Okay, so cortisol releasing hormone from placenta will go and fetus will go and stimulate the fetal pituitary. Fetal hypothalamus will release cortisol releasing hormone and placenta, and it stimulates the fetal pituitary, and the fetal pituitary produces adrenocorticotropic hormone, and this goes and stimulates the fetal adrenals, and again fetal adrenals will start producing cortisol, and this is the cyclical mechanism, and this cortisol will stimulate the placenta to produce oxytocin, increased prostaglandins, increased estrogen, increased progesterone, and increased interleukins. So these changes, once these hormones are high, it is the ideal situation for labor pain to start, or true labor to begin its process. So after that, the fetal adrenals also will stimulate the fetal liver, the ACTH, and it will secrete DHEAS, and this is responsible for increase in estrogen. So the main hormone here is estrogen, because the maintaining of pregnancy hormone is progesterone. So progesterone should reduce here. So should reduce. So the reduction of progesterone and increase in estrogen is ideal situation for contraction to happen. If progesterone increases, contraction will not happen, because progesterone is a relaxation hormone. So these are the changes which happens in fetus. Now, when we come to the mother, so what are the changes? Now, hypothalamus will stimulate the posterior pituitary, and we know posterior pituitary is the part which secretes oxytocin. And this oxytocin will increase the myometrial receptors for prostaglandin, oxytocin again, and there is increased gap junction, increased decidual prostaglandin, and increased stretch receptor number and sensitivity. So this all becomes ideal for uterine contraction. So once uterine contraction increases, the labor or the onset of labor has started. So these are the physiological mechanisms that happens in both fetus and mother. So one important hormone you have to remember is cortisol releasing hormone. It is related to labor. Next, possible mechanism, and this is not the mechanism, it is just probable or possible mechanism in initiation of labor. So activation of now in the previous slide we saw there is hypothalamus and pituitary of the fetus, which is coming into the picture. So why this is happening, this is not known. So the thing could be X factor. So one factor called X factor could be, and it is a query. It is not sure. This is the factor that is stimulating the activation or starting the activation of fetal hypothalamus pituitary adrenal axis, and this secretes cortisol, and cortisol will stimulate the placenta, and placenta, what it will do, it will increase estrogen and it will reduce progesterone, and this estrogen will again go and stimulate the maternal posterior pituitary, and this will secrete oxytocin. So it increases oxytocin, and oxytocin is the hormone which goes and stimulates placenta, amnion, chorion, decidua. So entire viable products of the pregnancy and the uterus. So what happens when this is done? Again, it is a cyclical mechanism. It increases oxytocin, prostaglandins, progesterone is prostaglandin E is increased, prostaglandin F is increased, and CAPS is increased. That is contraction associated protein, and nitric oxide is increased. So all these are responsible for activation of myometrial contractile system. So basically, we want uterine contraction. So only with uterine contraction, the delivery can happen, or the expulsion of the fetus can happen. So these are the probable physiological mechanism which is involved in the onset of labor. So always remember, progesterone is reduced. It is the hypoprogesterone state and hyperestrogenic state, because uterine contractions are very much necessary. Next, what is show? So we came across the word show in true labor pain. So what it is? So with the onset of labor, there is profuse cervical secretion, and simultaneously there is slight oozing of the blood from the rupture of capillary vessels of the cervix and from the raw decidual surface caused by separation of membranes due to stretching of the lower uterine segment. So in the further slides, we will be seeing what are the changes and what is happens with the formation of lower uterine segment. So when lower uterine segment is formed, there is light oozing of blood, and also there is profuse cervical secretion. So these two combined is called as show. The expulsion of cervical mucus plug mixed with blood is called show. So remember the definition: the expulsion of cervical mucus plug. So it is a cervical secretion Okay, show is not from the uterus, not uterine secretion, and mixed with blood is called show. And this is a definitive sign or the main sign to know that the true labor pain or true labor has been started. Next is events in first stage of labor. So what are the events? As you can see in the pictures, there are a lot of pictures, right? So we will go to the explanation and come back to the picture. So first stage of labor, what it is? It is preparation of birth canal. So we saw how many stages of labor? There are 4 stages of labor. So 4 functional stages. So here we are going to study first stage of labor. So first stage of labor is preparation of birth canal so as to facilitate expulsion of fetus in the second stage. So we know what is second stage. Second stage is expulsion of fetus and third stage is expulsion of placenta. And the preparation, the prep is done in the first stage of labor. And what are the 2 important mechanisms that happens so that the fetus is expelled? There is smooth expulsion of the fetus. First is dilatation and effacement of the cervix. If the cervix is not effaced, if the cervix is not dilated, it goes into the complication. So it is a very much necessary step for the expulsion of or the smooth delivery of the fetus. And next is full formation of lower uterine segment. Very, very important step, because without this, if lower uterine segment is not formed, then the expulsion becomes difficult. So we will see what happens in dilatation of cervix. So the predisposing factors which favor smooth dilatation of cervix are, so what are the reasons why dilatation occurs or what favors the dilatation of cervix? Because dilatation should occur in labor. So one is softening of the cervix. So we know cervical ripening is one condition which occurs in true labor. And fibromusculoglandular hypertrophy. So we know hyperplasia and hypertrophy occurs. So here it is fibromusculoglandular hypertrophy, increased vascularity. So these all we have studied in the physiological changes of pregnancy. So we all know why physiological changes of pregnancy is occurring. It is mainly for the preparation for the delivery and the after delivery phase. So the preparation of the entire body. So these are the factors that is favoring for dilatation. Accumulation of fluid in between the collagen fibers, breaking down of collagen fibrils by enzymes collagenase and elastase, and changes in various glycosaminoglycans, that is increase in hyaluronic acid, decrease in dermatan sulfate in the matrix of the cervix. So these are the 6 points which are necessary, which are the factors favoring the cervical dilatation, and these are predisposing. Predisposing means could be, these are causes. These are not actual causes. Now, what are the actual causes for dilatation? That means during dilatation, what are the causes that occurs? So the actual factors responsible is uterine contraction and retraction. So we know true labor pain is characterized by uterine contraction and retraction and fetal axis pressure. So there is fetal axis pressure and there is formation of bag of membranes which produces a pressure on cervix, and there is dilatation of cervix. And vis a tergo, this is a propulsive phase mechanism we will be seeing in the further. So what happens? It is just the preparation for the expulsion of the fetus. Now, effacement or taking up of cervix. So we saw the 2 important mechanism is, first one was dilatation and effacement of cervix, and second one was formation of lower uterine segment. So dilatation we saw. Now effacement. What is effacement? Effacement is a process by which the muscular fibers of the cervix, again this is related to cervix, are pulled upward and merges with the fibers of lower uterine segment, and the cervix becomes very thin during the first stage of labor and even before that in primigravide. So that is effacement. So thinning of the cervix and with pulling upward, the cervix being pulled upward, it is called as, and merging with the lower uterine segment is called as effacement. Now, what is lower uterine segment? During labor, the demarcation of an active upper segment and a relatively passive lower segment is more pronounced, and the wall of the upper segment becomes progressively thickened. So we have to remember, so for the expulsion of the fetus, the lower segment should not become thickened. It should be thinning. So only then it will allow the fetus to come down. So what happens? The lower uterine segment is formed how? It is thickened upper segment and progressive thinning of the lower segment. And this is pronounced in late first stage, especially after the rupture of membranes, and attains its maximum in the second stage. So that is formation of lower uterine segment. Now the pictures. Coming to the pictures. So here you can appreciate the cervical dilatation that is happening. And then here it is formation of bag of waters. Formation of bag of waters. And this is effacement. Effacement. So here you can see. So cervix, and again the size has reduced and it is pulled upwards. It is pulled upwards, and again it is pulled further upwards, and there is complete thinning of the cervix. So this is called as effacement, and this why it occurs? It is, so here you can see little water. So this is putting pressure also, and there are other factors also happening. Why? It is for the head to pass the vaginal canal and for the expulsion of the fetus. Now, formation of lower uterine segment. So the two parts which comes into a picture, or three parts which comes into the picture, is retraction ring, internal os and external os. So what happens? Internal and external os, they together combine. The internal os gets obliterated and they together combine. They form the passive segment, and with the retraction ring. So physiological retraction ring is a very important part in labor. Why? Because with contraction there is also retraction. So your retraction will help for easy expulsion of the fetus. So this is formation of lower uterine segment. Now coming back to second stage of labor. So first stage is over. Second stage, in the picture you can see there is some mechanism or some force that is happening on the fetus for the fetus to come down. Okay, so this force which is applied by the uterine muscles, the entire uterus, for the expulsion of the fetus, that is second stage of labor. So the second stage begins with the complete dilatation of the cervix. So we saw this complete dilatation of cervix and ends with expulsion of the fetus. And this stage is concerned with the descent and delivery. Descent and delivery, two words important. Descent means coming down and delivery is expulsion of the fetus through the birth canal. And there are two stages or phases which happens with it: propulsive phase and expulsive phase. Propulsive phase is full dilatation until head touches the pelvic floor, and expulsive phase is since the time mother has irresistible desire to bear down and push until the baby is delivered. So expulsive phase completes with the baby delivered, and propulsive phase completes with the head of the fetus touching the pelvic floor. Now, what is propulsive phase? With the full dilatation of cervix, the membranes usually rupture and there is escape of liquor amnia. And when liquor amnia is escaped, the cavity, the volume of cavity is reduced, and simultaneously uterine contraction is also happening, retraction is happening, and they become stronger. They become stronger with the volume reduced in the uterine cavity, and the uterus becomes elongated during contraction, while the anteroposterior and transverse diameter are reduced. So the elongation is partly due to the contractions of the circular muscle fibers of the uterus to keep the fetal axis straight, so that the descent is happening properly. So that is why uterus is getting elongated. Now, expulsive phase, what happens? Delivery of the fetus is accomplished by downward thrust, and this is with a tergo, and this downward thrust applied by the uterine contraction, supplemented by voluntary contraction of abdominal muscles against the resistance offered by bony or soft tissues of the birth canal, and this downward thrust is called as the tergo. And there is always a tendency of the fetus to push back into the uterine cavity by the elastic coil of the tissues of vagina and the pelvic floor, and this is prevented by what? This is prevented by the physiological retraction ring, which is responsible for retraction. So this is effectively counterbalanced by the power of retraction. And that is why the fetus is not pushed back. It is helping in the descent and expulsion of the delivery of the fetus. Thus, with increasing contraction and retraction, the upper segment becomes more and more thicker, with corresponding thinning of the lower segment. And endowed with the power of retraction, the fetus is gradually expelled from the uterus against the resistance offered by the pelvic floor. And after the expulsion of fetus, the uterine cavity is permanently reduced in size only to accommodate the afterbirths. And the afterbirths here is placenta and membranes. The expulsive force of uterine contraction is added by voluntary contraction of abdominal muscles, and this voluntary contraction of abdominal muscle is called as bearing down effort. Bearing down effort. So this happens in expulsive phase. So now coming to third stage of labor. Now we know the fetus is expelled. So we are with what? We are with remaining with afterbirths. Now what happens to the afterbirths? How the placenta and membranes are expelled. So that is third stage of labor. So here you can see the uterine cavity is empty. There is no fetus. Fetus is gone out. And the placenta is coming out. Now here you can see something called as placental surface. Placental PS means placental surface. Here in the first picture, you can see the placental surface is increased, or the length is higher than the second picture. Here it is reduced. So this is the mechanism which happens in third stage of labor. So the third stage of labor comprises the phase of placental separation. Again, here descent happens. So for the placenta to come out, there should be descent to the lower segment, and finally its expulsion with the membranes is the third stage of labor. So what happens in placental separation? So at the beginning of labor, the placental attachment roughly corresponds to an area of 20 centimeters. So here I showed you. So this is approximately 20 centimeters. So as the labor progresses, the placental surface reduces. That is the mechanism, one of the causes for the placental separation in the third stage of labor. And there is no appreciable diminution of surface area of placental attachment during first stage. First stage, it remains 20 centimeter. During the second stage, there is slight but progressive diminution of the area following successive retraction, which attains its peak immediately following the birth of the baby. So immediately after the birth of the baby, the placental surface is extremely reduced. And then what happens in the mechanism of separation? So marked retraction reduces effectively the surface area at the placental site to about its half. But as the placenta is inelastic, it is not elastic, it cannot keep pace with such an extent of diminution, resulting in buckling and expulsion. So after buckling, there is a shearing force is instituted between placenta and the placental site, which brings about ultimate separation. So the separation is actually happening. What is the main mechanism that is responsible for the separation? It is the reduction in the surface area, which the placenta is not able to take up or not able to bear because it is inelastic. And the plane of separation runs through deep spongy layer of Decidua basalis. So this can be a question. What is the plane of separation of placenta from the uterine cavity? It is the deep spongy layer of the Decidua basalis. So that a variable thickness of decidua covers the maternal surface of the separated placenta. Next, ways of separation of placenta. So there are two ways how a placenta is separated. So central separation, also known as Schultz separation. So detachment occurs from the center. So detachment of placenta from its uterine attachment starts at the center, resulting in opening up of a few uterine sinuses and accumulation of blood behind the placenta. So when there is accumulation of blood, this is also an added pressure on the placenta for it to get separated. And this accumulation of blood is called as retroplacental hematoma. So with increasing contraction, more and more detachment occurs, facilitated by the weight of the placenta, by the retroplacental blood, until the whole placenta gets detached. So this is central separation. How central separation occurs? Always remember the other name. It is also known as Schultz separation of placenta. Next is marginal separation, or Matthews, MM. Remember MM, Matthews-Duncan separation. Okay, so marginal separation or Matthews-Duncan separation. Here the separation starts with the margin of the placenta, as it is mostly unsupported. So margin usually doesn't have much support. The support is usually in the center part of the placenta. With progressive uterine contraction, more and more areas of the placenta get separated. But even though because it is mostly unsupported, more frequently marginal separation is the one that occurs. So most common type of separation is marginal separation. So here you can appreciate the types of placental separation. This is central, and this is marginal separation of placenta, and this is the retroplacental hematoma. Next, signs of placental separation. What are the sure signs of placental separation? Or during the during the third stage, waiting for the placenta to get separated, what are the signs that make sure that yes, placenta is getting separated? So, per abdomen changes are uterus becomes firmer, globular, and palatable. It is the earliest sign. Schroeder's sign. So this is important, a frequently asked question. It was asked previously. The fundal height is slightly raised as the separated placenta comes down on the lower uterine segment and uterus rests over it. So this is Schroeder's sign. And Kushner's sign. On pushing the uterus cephalad with a hand on the abdomen, the cord no longer recedes. So usually cord recedes if this is done, but now cord no longer recedes, and that is placental sign of placental separation. And there is a suprapubic bulge which may be seen. And per vagina, what are the signs? It is sudden gush of blood, because there is, once the placenta is separated, there is immediate blood loss which is happening, and permanent lengthening of the cord. Now, separation of membranes, how it happens. The membranes which are attached loosely are in the active part are thrown into multiple folds. Those attached to the lower segment are already separated during its stretching. And the separation is facilitated partly by uterine contraction and mostly by the weight of the placenta as it descends down from the active part. And the membranes are so separated carry with them the remnants of the residua vera, giving the outer surface of chorionis characteristic roughness. So the main thing which contributes to the separation of membrane is uterine contraction and weight of the placenta. Next, expulsion of placenta. After complete separation of placenta, it is forced down into a flabby lower uterine segment or upper part of the vagina by effective contraction and retraction of the uterus. Thereafter, it is expelled out either by voluntary contraction of abdominal muscle, that is bearing down efforts, or by manual procedure. So manual procedure. So we saw if active management is taken care of in the third stage, the time period is reduced. So that usually happens through manual procedure of expulsion of placenta. Next, mechanism of control of bleeding. So we know in physiological changes in pregnancy, we saw what are the clotting factors, or what are the changes in the clotting factors that happens. So why that change is happening? That is, the change is mainly happening to control the bleeding in the third stage of labor. Because once the placenta is separated, there is immense bleeding that occurs. But there is a mechanism which happens so that the bleeding is controlled immediately. So after placental separation, innumerable torn sinuses, which have free circulation of blood from the uterine and ovarian vessels, have to be obliterated. And the occlusion is affected by complete retraction, whereby the arterioles, as they pass tortuously through the interlacing intermediate layer of myometrium, are literally clamped. And myometrium is called, and this mechanism is happening in the myometrium. That is why it is called as living ligature. So this is a frequently asked question, which is the living ligature of uterine cavity, or which layer is the living ligature? It is myometrium. So that is myometrium. The living ligature is the principal mechanism of hemostasis. And however, thrombosis occurs to occlude the torn sinuses, a phenomena which is facilitated by hypercoagulable. This we saw in the physiological changes in pregnancy. Pregnancy is a state of hypercoagulable state. And that is why it is happening. It is so that during the third stage, it is helping, or it is aiding, it is preparing the entire body. This state is present during the pregnancy. Why? Because to prevent the bleeding. Apposition of the walls of uterus following expulsion of placenta, myotamponade, also contributes to minimize blood loss. So this is the changes which occurs in the blood circulation. So immediately, these are the myometrium fibers, muscular fibers. This clamps the blood vessels. So that is how it is giving a picture of ligating, and that is how bleeding is controlled. Next, mechanism of normal labor, very important, very important, usually asked or repeated question. So what happens? So we can see in the picture what is happening. So the head is entering into the pelvic cavity, and then it is coming out, and there is expulsion. So head has come out first, and then there is shoulder, which is coming out second. So we will see what happens in mechanism of normal labor. So the series of movements So movements here, not events, here it is movements that occur on the head, mainly head of the fetus. In process of adaptation during its journey through the pelvis is called mechanism of labor. And it should be borne in mind that while the principal movements are taking place in the head, the rest of the fetal trunk is also involved in it, either participating in or initiating the movement. Next, what is the mechanism? The position usually in mechanism of labor, the position usually attained by the fetus, it is either occipitolateral or oblique occipito-anterior. The engaging anterior-posterior diameter of the head is either suboccipito-dragmatic. So you should know there are two diameters, anterior-posterior diameter and transverse diameter. So the engaging diameter, anterior-epidiameter is usually suboccipito-dragmatic or suboccipito-frontal. And the engaging transverse diameter, the transverse diameter is usually biparietal diameter, which is 9.5 centimeter. Now here, principal movements. These are the most important part when it comes to exam point of view, because the sequence of it occurring is asked directly. So you should know the sequence. First is engagement occurs, then descent happen, and descent is a continuous process. It is not that once descent happens, it stops. No, descent happens till the fetus is expelled, and then there is flexion and internal rotation, crowning happens, extension happens, restitution happens, external rotation happens, and then expulsion of the trunk. So this is the 9 steps, and this 9 steps you have to remember in the order, proper order. One order also gets here and there or mixed, then you will lose marks. You will lose marks because it is a frequently asked question. There are few guidebooks which give few mnemonics for it. So I would suggest aspirants to go through. Next, engagement. What happens? Engagement is said to occur when the greatest transverse diameter of the presenting part has passed through the pelvic inlet. So that is called as engagement. And in all cephalic presentations, so the greatest transverse diameter is always biparietal diameter. And engagement occurs in multipara with the commencement of first stage of labor, late first stage, after the rupture of membranes. But in nullipara, it is last few weeks of pregnancy, that is 38 weeks. And in primaries, the most common cause of non-engagement, a term is deflexed head occipito-anterior position followed by CPD, cephalopelvic disproportion, is one condition which is responsible for the non-engagement of the head. Engagement of head rules out CPD at the level of pelvic inlet. So which is one thing which rules out the CPD, it is engagement of the head. And if the head is engaged, it means head is at zero station. So stationing of the head is assist for the true labor or expulsion of the fetus, whether it is occurring properly or not. So here, if it is engaged, the head, it is at zero station. So there are two types of engagement, synclitic and asynclitic. So synclitic, here the sagittal suture of the head of fetus lies in the transverse diameter of the pelvic inlet. So midway between pubic symphysis and sacral promontory, and it occurs in 25% of cases. Whereas asynclitic, it is anterior and posterior. Two types again. An anterior is sagittal suture is defected towards sacral promontory. Also anterior parietal presentation of Naegele's obliquity, and it usually occurs. So anterior asynclitic engagement occurs in multipara, and posterior asynclitic occurs usually in nulliparous women. So sagittal suture is defected towards pubic symphysis here. Here it is sacral promontory. It is here in synclitic, it is between pubic symphysis and sacral promontory. And here in posterior, the posterior parietal bone thus becomes leading part. Also, Litzmann's obliquity, it is also known as. So here you should remember the other names. Anterior parietal presentation means anterior asynclitic engagement, or Naegele's obliquity means anterior asynclitic engagement. And in posterior, it is Litzmann obliquity means posterior engagement, asynclitic engagement. So it occurs commonly in nulliparous women. Next, so I have taken only the important point in all the steps. So you have to remember descent is a continuous process which occurs continuously. Yeah. So flexion, what is the theory associated with flexion? Why flexion occurs? Just remember it is called as two-arm liver theory, and internal rotation is the most important step. So it can be asked, which is the most important step among the movements in the mechanism of labor? It is internal rotation. Internal. Why? Because if in internal rotation doesn't happen, then next crowning and descent will not occur. The further crowning, the further descent will not occur if internal rotation is not happened. So that is why it is most important step, and it is based on the law of pelvic floor. It is also called as Hart's rule, and law of unequal flexibility, also called as Selheim and Moir rule or law. Next, crowning, and important in extension, it is couple of force theory. Couple of force theory. So just remember, these are the terms, or these are the theories that you should remember. The names of the theories are important. Next, what is normal puerperium? Normal puerperium. Puerperium is a period following childbirth. So the childbirth has happened, that means the fetus is delivered, and during which the body tissues, especially the pelvic organs, revert back. So getting back to the normal, or getting back to the normal physiology without the baby or without the fetus, is normal puerperium, approximately to the pre-pregnant state, both anatomically and physiologically. And the retrogressive changes are mostly confined to the reproductive organs. So because maximum changes has occurred in the genital organs, that is why. And with the exception of mammary glands. Why exception? Because lactation. So this one, the physiological changes in mammary gland has nothing to do with delivery actually. It is actually preparation for lactation. So that is why the regression or retrogressive changes will not occur in mammary glands, which in fact shows the features of activity. Next, involution of the uterus is a process whereby the genital organs. So involution occurs in all genital organs, revert back approximately to the state as they were before pregnancy. And the women who is undergoing the normal puerperium is called as puerpera. Puerpera. So duration, this is important. Puerperium begins as soon as the placenta is expelled and lasts for approximately 6 weeks. 6 weeks. So this duration is important. When the uterus becomes regressed almost to the non-pregnant size. So what time period does uterus take to come back to the normal size? Pre-pregnant state, it is 6 weeks. Next, the period is arbitrarily divided into immediate, early, and remote. So immediate is within 24 hours. The regression happening, and up to 7 days, and remote is up to 6 weeks. So maximum it is 6 weeks. And next, one associated condition after puerperium or in puerperium after the delivery, the 4th stage is PPH. That is postpartum hemorrhage. So I have taken few abnormal conditions so that it is completed with this. So what it is, PPH. So quantitatively, if we have to give a number or a statistics, it is a blood loss which is happening. So postpartum hemorrhage is happening. So postpartum means after the delivery of the fetus. So hemorrhage is happening in excess of 500 ml after the birth of baby, or drop or reduce in hematocrit by 10%. So this is the quantitative details of PPH. The definition is any amount of bleeding from or into the genital tract following birth of the baby leading to signs of hypovolemia. So any bleeding directly leading to the hypovolemia, it is with the signs of rising pulse and falling BP, it is PPH. It is PPH. And PPH, most common cause of maternal mortality in India. So maternal mortality in India, the most common cause is postpartum hemorrhage. And primary PPH means which is occurring within 24 hours after the birth of baby, and the most common is within first 2 hours. So most common time period in primary PPH is within first 2 hours, and it occurs most commonly after the expulsion of placenta. If the PPH is occurring after expulsion of placenta, it is called as true PPH. And if it is occurring before the expulsion of placenta, it is called third stage hemorrhage. Because third stage is related with expulsion of placenta, and if PPH occurring before the expulsion, it is called as third stage hemorrhage, and if it is occurring after expulsion, it is called as true PPH. And most common cause, very frequently asked question, this is most common cause of primary PPH is what? It is atonic uterus. You would have seen in all previous year question papers, it is a frequently asked question. So the most common cause of primary postpartum hemorrhage, primary postpartum hemorrhages, atonic uterus, and other causes which are related to trauma, retained tissues, and blood coagulopathy. Next is secondary PPH. So beyond 24 hours. So within 24 hours is primary. Beyond 24 hours and within puerperium, that is 6 to 12 months, it is called as secondary PPH. And most common cause here in secondary PPH is retained placenta, retained placental bits. And in atonic PPH, uterus is flabby and becomes hard on massaging, that is primary. And in traumatic PPH, uterus is found well contracted. Now, how do you diagnose postpartum hemorrhage? It is by shock index. Shock index. Because there is hypovolemia, the woman is going into a state of shock. So assessing shock index is the most important, and this is also a frequently asked question. So what is the criteria, diagnostic criteria for PPH? It is shock index. And what is shock index? It is heart rate divided by systolic BP, not diastolic, it is systolic BP. And normal range is about, if we calculate our, whoever is not in shock, if we calculate, our range will be in 0.5 to 0.7. And a woman or any patient who is going into shock, the value is more than 0.9 to 1.1, 0.9 to 1.9, and that is suggestive of PPH, which needs immediate resuscitation, And there is also known as obstetric shock index. There is something called as obstetric shock index, and here the number is, that means obstetric shock index means shock occurring due to obstetric cause, especially PPH. Here the value is not 1.1, it is more than 1. So obstetric shock index, if it is more than 1, it is suggestive of PPH. It is suggestive of PPH. Next, perineal tear. First degree perineal tear, injury to perineal skin only, the perineal body remains intact. Second degree is injury to perineum involving perineal body, excluding anal sphincter. Okay, so it is a mediolateral episiotomy corresponds to second degree perineal tear. Third degree is complete, which is the complete perineal tear. It is third degree. So it involves major laceration of posterior vaginal wall, tear of perineal body, including anal sphincter. And fourth degree is third degree with involvement of complete anal sphincter is fourth degree. So just remember, this can be asked as a match the following question. Next, placenta accreta, a condition which is occurring. This is morbidly adherent placenta anchored to the myometrium, and which is related with the retained placenta. So decidua basalis and Aiapget's fibrinoid layer here are as absent, and penetration of villi. If the placental villi penetrates into the muscular layer, it is called placenta increta, and if it is serosa, it is called as percreta. And risk factors for placenta accreta is placenta previa, which will be dealt in the in a different session where we are discussing all the hemorrhage part in pregnancy and previous C-section. If these are the risk factors for placenta accreta, and prior uterine surgery, any surgery related to uterus, it is the risk factor for placenta accreta. Now, diagnosis. So placenta accreta is can be diagnosed only clinically. There is no any diagnostic criteria or invasive criteria which can be which can be made use of for the diagnosis of placenta accreta. During attempted manual removal of placenta, when the plane of cleavage between placenta and uterine wall cannot be made out, then we have to understand that this is a case of placenta accreta. Next is Bishop score, very important. So we were speaking of head station, cervical effacement. So we'll see what is Bishop score. So Bishop score is a quantitative method for the prediction of successful vaginal delivery following induction of labor. So this phrase is very important. So Bishop score is to assess what? It is to know the progression of labor after inducing labor. So after induce, for whatever reasons it may be, induction of labor is done, and to assess the progress of the labor, Bishop score is done. So what are the criteria used in Bishop scoring? It is fetal station or the head station, which is the distance of presenting body part above or below ischial spine. But if it is in the pelvic cavity, engagement has happened, the station is 0. Now from this 0, it can go to 1, 2, or -1, -2. Next, cervical dilatation in centimeter. The maximum can be 10 centimeter. Cervical length or effacement. So there is something called modified Bishop score. In modified Bishop score, effacement is removed. Effacement is removed and cervical length is added. And in proper Bishop score, it is effacement in percentage. And cervical consistency. This is with relation to the ripening of the cervix and cervical position. Cervical position. So this is Bishop score. And also there are a few questions which is asked to till now. Two scores are important in obstetrics, Apgar and Bishop. So Apgar is asked as a part of calculating, that calculate the Apgar score, the question is formed that way. Whereas in Bishop score, it is the criteria. So what are the criterias in the Bishop score? What are the, it can be none of the above or any of the above, or which is not a criteria in Bishop score. These are the type of questions formed from Bishop score. But maybe from in the future, there can be questions for calculating also. So I suggest aspirants to go through the complete table of Bishop score, which is this. So it can be as a scenario, case scenario can be given and you will be asked to calculate the Bishop score. So also remember these are the criterias, important criterias on which Bishop score is calculated. So this completes the topic. Thank you. Thank you, Focus.